Thank you very much. Good morning, everybody. Got a bit of imposter syndrome listening to all of that because I still feel like a young nurse, still feel like I've got lots to learn. And it's hard work, isn't it? Working your way through your career, chipping away, studying. Last week I handed in an assignment for my master's and I'm thinking, when is this ever going to stop? But if I'm honest, it's these venues, where we can engage together that I enjoy the most. So thank you for inviting me along today. I hope you enjoy my presentation. So as you know, I work in Leicester. My history has always been within burns and plastics. I don't look after patients with major burns, just small minor burns, but wound care and reconstruction is my speciality. So if you've lost a part of your body through trauma, through cancer, or congenital abnormality, then our aim is to rebuild that. I've got a special interest for breast reconstruction, nipple tattooing, so rebuilding ladies, and one of my favourite things that I do is run a breast reconstruction support group where we all get together and the ladies show each other their new reconstruction. So that's just a little bit about what I do in the daytime. I became a specialist nurse about 11 years ago. I was a ward sister and I thought, I'll just be a specialist nurse. I'll be swanning around, you know, from when you've transitioned from being a ward sister thinking, I'm going to have a really nice, chilled, relaxing life. Just me on my own, no staff to look after. How was I so wrong? You start realising all the gaps in the service, and over the last 11 years, I've developed a team of up to 8 of us and tried to transition our education to master's level and upskill our nurses and develop lots of services. But we all know how challenging that is, especially within the current climate of COVID. When you want to expand services and you want to take things forward, we're a bit stuck at the moment. So I've got a special interest in getting the whip out and challenging those barriers, and I've got myself in trouble a few times for being very vocal, but we are the patient's advocate, and unless we're their voice and pushing for the patients, then sometimes things don't move forward. This is just a usual disclaimer. This is our plastic surgery team. We're a really small team, 6 consultants and 7 specialist nurses. And obviously we've got our 2 base wards. So each of the surgeons have got their own speciality of what they like to specialise in. One likes to specialise in breast reconstruction, one likes to specialise in hands, one specialises in burns. Trying to, I'd say, gently groom them, one of them in particular, to come on board with some of the pressure ulcer reconstruction. Pressure ulcer reconstruction falls under the care of plastic surgeons, but they don't find it very attractive. They find that's not their favourite job, so quite often when we're trying to refer a patient, they will all try and pass the buck a little bit. So we finally found someone to come on board, and we are trying to develop a surgical pathway for these patients, and instead of them bouncing between different services, orthopaedics, tissue viability, district nurses, and then they get referred to us, can this patient have reconstruction? And we're finding, you know, people who work in silo is so difficult because there's no go-to person. So we're trying to establish a pathway. So watch this space. It's a slow process, but we're trying. And I was just saying to Fran earlier, during the pandemic, we've seen, and I've not seen this in my nursing career, I've been qualified for 25 years, I've seen 2 patients in the last year with necrotizing fasciitis related to a pressure ulcer. I've seen neck fash all the time, but not related to a pressure ulcer. And that sets my alarm bells ringing. What's happening out in the community for the pressure ulcers to develop in such a way for them to have necrotizing fasciitis. And once you've had necrotizing, it's very difficult to reconstruct with such a large wound. So this is some of the things that we do in our team. When I first started, I didn't kind of know what I was going to do because we hadn't had a specialist nursing service for plastics. Kind of had a passion of what I would like to do. The main aim that we've been trying to introduce is complex wound care clinic. So we will have referrals from GPs, from community tissue viability nurses, of how, any wounds that might need skin grafting or surgical reconstruction. And one of the things we found during the pandemic to support our community colleagues is our E-Referral System. Because historically what we found is our tissue viability nurses struggle to get the GPs to refer into us, and all the referrals I get, I can tell that the GP's been prodded by a district nurse or tissue viability nurse. I can tell that they practically wrote the referral and he's just signed the bottom of it. And I feel that the GP is sometimes the middleman, and we try to empower us as nurses and think, how can we communicate together? Because often we know about the referral before we've got it because we're friends. My friend in the community calls me and says, we've got this wound. Oh, I can't see it until we've got the referral. So we've set up a refer a patient referral for lower leg trauma and wound care, and we'll accept referrals from our tissue viability nursing colleagues now, and it saves that whole middle ground of the GP, and we can communicate much quicker. And instead of a little email chat, it's all formalised. So that's been really successful and really beneficial during the pandemic. In Leicester, we cover plastic surgery right down to the East Coast. So patients might travel 150 miles for surgery, and sometimes some of the elderly patients travelling all the way for assessment of their lower leg can take them a 4-hour trip both ways. So doing the referral system definitely helps. Some of the things we do in our clinic, sharp debridement, obviously out in the community as well. We do medical tattooing, mostly for women that have need their nipple and areola had in colour. But we also do, so if you've been involved in a burn explosion and you've lost your eyebrow, I've done some fake stubble on a man once because he had stubble on one side and not the other. Really enjoy that side and the camouflage. I think when we think about patients with wounds and the healing, their psychological impact of their scarring long term can have a great deal of an impact for them. So we have a camouflage clinic once a month where we've got all our products, and we will teach the patient how to conceal the scar if they want to. It's not just a camouflage clinic, it's a chance for us to do a psychological screen on them, ask them how they're doing and how they're integrating. It's a lovely clinic, and you feel like a nurse for that day. You feel like you're doing a really good job having the time to talk to a patient. We do lots of trauma. We're not a trauma centre, but we do lots of hand trauma, so lots of hand wounds. Dressing fingers takes forever. None of the nurses like to dress. The doctors hate dressing fingers because they're fiddly, but we've got a few knacks and tips. We do little minor ops in our clinics. The outreach service is invaluable to us because we do lots of joint working with tissue viability and our district nurses. Saves the patients travelling all the way to our hospital. We can do sharp debridement out in the community. We've also started to review the pressure ulcers for surgical reconstruction. So because I've done the consultation skills and prescriber, instead of the patient having to catch an ambulance and be hoisted in an outpatient clinic, and I'm not having a panicked phone call from the plastic surgeon, I need help quickly, can you come down? We can go and do that full assessment at home, meet the family, and present the surgical opinion to the surgeon and make a decision collectively. The complex wound clinic is mostly complex lower limb wounds for view of, do we need to do some soft tissue coverage or do we need to do a skin graft? The breast reconstruction clinic that we do, we also cover now the wound care for maxillofacial patients, and we have a specialist nurse go round every day on the ward rounds to follow the team to see which wounds that we think that we could input or patients that we could go and visit out in the community. It's a lot, and there's not many of us. So you can imagine during the pandemic, it was, okay, let's have 2 nurses go off on shielding like many nurses did. And it was like, right, what of all of that needs to go, including the nurses? Where are we going to be moved to? What are we going to do? And for me, it's taken me 11 years to grow that service. I don't want to let any of it go. And it's about judging that priority and that risk. So we changed our services overnight tremendously. Camouflage, tick that one off the list, sadly. Medical tattooing, that got chopped off the list. Our breast reconstruction clinic got chopped off the list. We've got a waiting list for 2 years now for women to have a new breast made because of the impact of the pandemic. Our wound care service to the maxillofacial department, that ceased. So lots of the things left. What we did manage to keep was our complex wound service. And during the pandemic, we increased our home visits. And it was an argument between me and our hospital managers, well, we're going to move you all. And I said, if you move us, we'll have an increased rate of admissions with complex wounds. We're keeping people at home. We're coordinating their care. So the agreement was we'll go out in the community more and support our community colleagues if we didn't get moved, which we didn't. So there's a few of us in our team that will go out on the roads, our community outreach service. And we usually go out 1 or 2 days a week, and we cover such a large patch. So for burns, we cover a big radius because we're a burn service. And we started to visits on three days a week. And this was new referrals, so it's preventing patients to coming into A&E. We'd go and do all the haematoma evacuations at home if we felt that was safe to do so. And any trauma operations, instead of bringing them back to our clinic, we would go out to their home and do their wound care clinic in their own home. Sometimes we didn't have the capacity to see them all, but we'd risk assess those patients with high comorbidities that we felt were unsafe to travel back. We did over 500 visits just in a really short space of time. And I know my bosses were really worried about us catching COVID, but during this time we felt safe. None of us caught COVID while we were out in the community. I caught it at Christmas when I was off work. So, but everybody's story is different. What COVID did for us was increase our technology referral systems, and that's something we hadn't embraced previously. We've still got this work in progress, actually, and I think when we think about COVID, we think, what things do we want to keep and what things are we glad that can go? And I think that virtual clinics is a way forward for us. A little bit initially I actually want to see the patient face to face, I want to be able to touch them, see their expressions. But actually some of our young adults, especially with minor burn injuries, are happy to change their own dressings if we supply them with the right information. And we are just in the process of setting up a system called Accurex, where we can do a video link with them, and the day before they can send us 5 pictures of their wound. Because our original system in the hospital was just video link. And I said, well, if a patient's got a bandage on at that point, then we don't want to, the telephone call, the video call would be ages while they unwrapped it. So hopefully we'll go live in a couple of weeks. So we've also got this little advice sheet, like from Wounds UK, of best tips of how to take a photograph of your wound, because sometimes we get pictures in from patients in which part of the body does that belong to? As we all know. So telephone clinics, video virtual clinics is something we want to keep. It doesn't replace our input, and it's for those patients that are happy to do that. So our outreach service, we've gone back down to 2 days a week because other services have restarted back up. But we definitely feel, we had one patient actually during the pandemic. She was a burns patient, and her husband was on intensive care with COVID at the time, and she was cooking for her children and her clothes caught on fire. And she ran out into the streets, and because of COVID, no one would come out and help her. She was on fire. So she had, not only did she have all these significant burn injuries, her husband was in intensive care, and she had 2 teenage sons. So our outreach service during that time, we were visiting her twice a week. The emotional support, we felt part of that family by the end of it. And her husband came home safe, and she's still having ongoing care regarding her scar therapy. We managed to do all her wound care at home. We managed to support her getting in the shower. We managed to support all her showering. So now I'm just going to talk to you about some case studies that I have, just to kind of share my journey with using topical negative pressure. So this is what we see. So, sometimes when we look at a patient, if the wound on the left, it's a small wound. And, you know, our doctors will look at that, and some of our junior nurses are just a hole. It's just a small hole. But actually, sometimes we find that it's the small chronic wounds that are the persistent ones, that because they're not big and the patient's mobile and walking around, we don't need to think or look about them. And my message is to my team is it's not just a hole. Let's look at what the impact is for the patient. What impact is this having for this lady? And this was a lady, actually. She was a healthcare assistant in our trust. Absolutely desperate by the time we got to her. And my feeling is sometimes is that people get to us too late. What's happened? What's been happening over the last year? Why haven't we ignited and got things moving again? So just to give you a little bit of a story about her, she'd had a laparotomy. She was unwell. She had sepsis and intensive care. And she had complications with her wound. She had a 5 centimetre sinus. She's only 32. Comorbidities, which, you know, go alongside with the chronic wound. She'd been on, by the time she'd come to our service, she'd been hopping on and off antibiotics because the GP didn't know what to do. Repeated infections. She'd been on sick leave the whole time because she had high exudate levels. It was leaking through onto her uniform. She was really conscious of any odour. No confidence, and she had a really negative body image. She was changing her dressings herself, but then obviously she was being reviewed by the district nurses just to see if anything needed to be changed. She'd gone through, we asked her, what dressings have you had on this before? And you just really reel them off. I think that everybody's tried a little bit of everything. What she found is the lack of consistency in advice and care. And my feeling is she was being maintained. We weren't actively treating. And this is my feeling sometimes, is that we need to start becoming more active. But we can only be active when we know about the patients. So this was on the left-hand side, just a little picture of a probe in the wound, which was 5 centimetres. We opted for a disposable negative pressure device because this lady really wanted to get back to work. And she said, is there any chance that I can go back to work with this device in place? I said, as long as your manager is happy, as long as there's no wires and it's in your pocket, I can't see why not. We decided to use a protease modulating dressing with silver in the wound bed to pack it because of the chronicity of the wound. And this was the second time I'd piggybacked these two applications together. The first time I'd done this is with pilonidal sinus that had not been healing. And I decided, because the wound is chronic, but I wanted negative pressure, just to, you know, I didn't read the evidence. I just had a little go and a try, as we do as a nurse when we've run out of solutions. And for the patient with the pilonidal sinus, I was seeing such a difference. I was like, oh, that works. And this is how we start evidence, isn't it? So I did it with this lady. And each time she came back to the clinic, we did it twice a week. We managed it within our clinic. We were like, we're taking your care over. She'd come back twice a week with the uniform on, really happy, going back to work. The dress had never fell off at work. She had no odour. She didn't go on any more antibiotics. And by week 4, you can see just a bit of a dry crust in there where it's re-epithelialized. And this was 4 weeks. So you think how long she's had her wound. It just needed a bit of what we call a challenge, a wound care challenge. So that's that lady. So yeah, she was happy to go back to work. So how do we measure the outcomes? As nurses, we measure it by patient feedback and having that feeling that she feels more confident again. We know she's been able to go back to work. She didn't need any more further antibiotics. The impact reduced district nursing input for them, and also for her, she's not needing to change it every day. And we felt like it was an active treatment plan and reduced her healing time. This is the thing sometimes with these small wounds, they think they get left sometimes because we've tried all the different dressing types and then we don't know what to do, and the patient then becomes self-managing, so they kind of drop off of everybody's radar. This is a case study of a lady. She's 25 years old and she had breast cancer to the right breast. She's got a little son. She's doing really well at the minute. I've just tattooed her some nipples on, doing absolutely brilliantly. She had a mastectomy on the right side. She had to have radiotherapy. She's a smoker. And we reconstructed her breast using her abdominal tissue. Because of her risk factors, she wanted to carry on smoking, patient choice, and her skin, because of the radiotherapy, was damaged. We had a 7 centimetre cavity, and I lost the wound probe about 7 centimetres medially. Again, this dressing would never stay in place. She tried all different things. We packed it with Aquacel AG, with dressings over the top. And we, to be honest, we left this for a few months because she was self-managing. She'd come back once a month. We're like, well, we're not really getting anywhere. So we decided to go for a disposable negative pressure again. I've not got the picture of the end. This was quite challenging, actually, because of the breast fold. And we did manage to get the seal. We changed the dressings for her, and she managed to go back to work with a device. She could still pick up her son. And the wound did heal. And she's an advocate now in our breast reconstruction support group. She shows other ladies that are considering having surgery. So just want to talk about the cost and the burden of wound care. They said that £8.3 billion was spent on wound care between 17 and 18, which is a 48% increase. Why we spend so much money on wound care? The cost is growing every year. Now, my feeling is it because we have so many chronic wounds out there, have we got the right treatment plans for the patient? You hear about as well the government saying there's been loads and loads more district nursing visits. Brilliant. But actually, it's not that we've got more district nurses. I work with district nurses and there's more visits happening because they've got a high caseload. I remember going out to do joint visits for district nurses, and when I do joint visits with them now, they're like, I've got to go, can you do the dressing? I'm like, absolutely, you go. They've got a caseload that's unmanageable. And it's not a surprise that we have so much chronicity, because I know the feelings with a lot of my colleagues. They haven't got the time and haven't got the support and the leadership backing them sometimes to follow all the processes that they know that might be beneficial for the patient. Also as well, wound care has been handed down to unqualified members of staff. There's pros and cons with that. I think that there's lots of pros if it's managed in the right way and it's not just seen as a sidestep, and the patient's still getting those thorough assessments by those members of staff that are qualified and trained to do that. So the impact of COVID we've found on the burden of wound care. What I've found is that we've had surgical reprioritisation during COVID, is that we weren't allowed to operate on anybody unless it was life-threatening. Now, I had a massive long waiting list with our surgeons of all our chronic wound patients that were going to come in for X, Y and Z. And telling those patients that had already waited a year anyway that, sorry, your operation's not going to happen now. We had a couple of patients that were due pressure ulcer reconstruction. We'd planned for a year for this, and those plans have gone out the window. So that's taken us a long time to try and get things back on track. We think about the psychological impact as well. I know there's been some studies as well, hasn't there, about the increase of depression and anxiety with patients with wounds during the pandemic. And we've tried our best to reach out to say, we're still here for you. And even during COVID, our breast support group we managed via Zoom. And they were like, when can we have our operation? We've been trying to keep patients as engaged as we can. What I've noticed as well is that we've not been able to implement our first choice. And sometimes with negative pressure, that's our first choice, but we haven't been able to do it. The district nurse, I haven't got anybody that can go out and change the dressings. Obviously the skill mix, we've had lots of people retire, we've had lots of people redeployed. We have a skill issue with topical negative pressure, I think, and I don't know if anybody else has found that in your area. We've got the same as inpatients on the ward, staff have all moved around, and it's time now that we get back to training. And we're happy that we're allowed to have our trainers to come back into our trust and start our training programmes again, and just start to reignite that passion, which we've been really happy about. This is just, you might come across this. You don't think you're interested in this actually. You might come across it in your, has anybody ever seen a swelling like this on a patient before? No, in plastic surgery, we kind of take care of these patients, but it's just to kind of talk through their post-operative care. So this is called a Morale Laval. And it was named after a radiographer in France. I probably pronounced that wrong. And it usually happens on the trunk region after trauma, so after a direct impact. And what it is, you'd think it was just a seroma, but it's a large capsule that's encapsulated full of fluid that needs surgical removal. Historically, we've had lots of problems after this surgery with recollection of seromas, dehiscence, and especially because they're over the trunk area because of movement on the body. So I just thought I'd show this little case study because we don't come across these very often, and one day you'll see one and you'll say, oh, I remember that day, I remember that nurse talking about that. So it's just to give you an idea of what it looks like, how large that cavity is. And you can imagine taking out that large capsule, that risk of seroma reformation, the risk of dehiscence. And that's what it looked like. And obviously it was full of fluid at the time. It's really fibrous, lots of scar tissue. Historically, we used to try and aspirate them, and then we realised they're just, yeah, you've seen one before. Yeah. So our post-operative wound care was the incisional line negative pressure. Because it was over a joint, it was over an area of flexible mobility, and we knew that if we had dehiscence here, the chap had high comorbidities. So we decided, this was the first patient actually that I'd applied this to, and we were amazed with the results. So at week 1, we removed it, and I was like, well, why did we take that off? That could have stayed on there a lot longer. So I'm pleased now that there's the 2-week solution for that can be left on for 2 weeks. Patient had, after we took the dressing off, had a really nice, robust scar, and it didn't reform. We probably do 1 a year, not very many, not very many. This is a wound that is notoriously in plastic surgery. If anybody's looked after ladies that have had breast reconstruction using their abdominal tissue, risk of dehiscence. Risk of dehiscence in the abdomen is quite high because they have to remove sometimes the muscle, but all the subcutaneous skin. The scar is from ear to ear. And they have to remove a lot of subcutaneous skin and fat because they're plumbing it into the chest wall area. What we used to use was an abdominal binder post-op, because as you can imagine, resuturing that back up, the ladies are very tight. They walk hunched over, they're scared to cough, they're scared to sneeze. We're propping them up in the bed with their knees bent, and we're keeping them in bed for 24, 48 hours. During COVID, and I've actually just done my assignment on it, so I feel like I could talk about it forever. We're looking at enhancing people's recovery, getting them out of hospital quicker. So one of our methods, and I pinched it off of an idea from one of my colleagues in London that told me that she was trialling this, and we always like to share ideas and phone each other up and ask what's happening. And what we found with the abdominal binders was that they would ride up, and sometimes they'd put pressure on the reconstruction. So we started to use the incisional line negative pressure method. What that allowed us to do, because the enhanced recovery process during COVID, we usually keep these ladies into 5 to 7 days. And by adopting some enhanced recovery principles, the aim was to get them out on day 0, if we could get them out of recovery quick enough, or the morning of day 1. And that was a real big shift and change in our practice. And our biggest concern was dehiscence of the abdomen, because we know they're notoriously tight. So for us, we've only have obviously just restarted to do surgery, and so far we've managed to reduce our length of stay from 5 days to 3 days. There's other things as well as the incisional line negative pressure that we've been adopting. Early mobilisation with the physio. We've started to do preoperative carbohydrate loading. And some of the big centres have been doing this a little while, but we're a smaller unit and we're catching up. So now this has become standard of care for our post-op recovery, and we are looking at our data, and we'll be collecting our data over a period of time just to see whether this is going to reduce our dehiscence. So far, we haven't seen any abdominal dehiscence, but we've only restarted surgery not that long ago. And you can see she's had a belly button replaced. It's amazing when they do the surgery, the belly button's freestanding on like a little cord, and then when they suture the abdomen back together, the surgeon thinks, where's the dot in the middle where we're going to put the navel? He has sometimes got it a little bit off piece. So this is an interesting story, actually, I'd like to share with you. And this is where I'm really proud of this. This is all nurse-led. Didn't need to go to theatre. He's a 58-year-old male. He presented to ED with a deep tissue injury after a long lie. We think he overdosed. Complex psychiatric history, which I wasn't aware of initially. He had delusional psychosis. He told us he was ex-paramilitary, had all the gear, and we were in awe of him. And it turns out he'd never been in the services, but he didn't find that out till a little bit later on. He excessively smoked. He was off the ward a lot, going home sometimes. Concordance was variable. He was a high anaesthetic risk. He had LVF, extensive cardiac history, diabetic. Every anaesthetic nightmare. And also, if you have a little look, this was to his right buttock. He'd been self-managing this for a little while. We've all smelled wounds, but this was probably one of the most malodorous wounds I've smelled. It was awful. He was having children in the shops follow him, and they could smell it. And if you look at the picture on the left, it was really, really spongy. It was a bit like a waterbed. And he was in my wound care clinic, and I've started to debride, and a little bit more, and a little bit more. And I'm thinking, how much deeper is this going to go? I was quite surprised. I got to the wound bed, as you can see there, and I was like, this is where my competency, I'm starting to feel like I'm going to be getting down to the muscle. So this was what he looked like after we'd debrided it. So quite a large cavity. We would ordinarily do buttock rotational flaps. There's no way he would be concordant because of his mental health history and his smoking with the post-op recovery that would be needed for it to be a success. Massive reconstructive challenge. And in reconstructive surgery, we have a reconstructive surgery ladder. We like to start on the bottom and then work our way up. Big surgery is more high anaesthetic risk and longer time in theatre. And if it goes wrong, you've got 2 big, large wounds. So we try and start from the bottom. So he got admitted directly from our wound care clinic. And we commenced negative pressure wound therapy with installation. What we wanted to do was to clean it, but we also wanted the negative pressure. So what we did, we took the ordinary wound swabs that we would do. With installation, we always use saline. I think the evidence out there is the saline is as good as any other product. I've used Prontazan before, but to convince the ward nurses how easy it is to use, I could say, can you put up a bag of fluids? Yeah. Can you use negative pressure? Yeah, well, you're fine. It's a little bit of a worry when we're seeing new equipment sometimes. So on this patient, what we did, we had a soak time of 10 minutes. And then we had negative pressure for 3 hours at 125 milligrams of mercury. We changed it twice a week. And as you can see down the pictures, the wound bed's starting to look much cleaner. We use the cleansed choice foam because that can help hydrate any residual biofilms and help hydrate that so it can be removed. And as you can see, by day 5, the wound bed, rich granulation tissue. By this point, he was off the ward more than he was on the ward. And because we'd achieved a clean wound bed, we felt confident to swap him over to a standard negative pressure therapy device. He did come back to outpatients clinic, and this was his picture, 2 centimetres at 8 weeks. So we were proud, it's all nurse-led, and he didn't need to undergo any surgery. Not that I would have convinced a surgeon to do that. So this is a picture of a lady that I'm going to share with you now. So in Gibraltar, we cover plastic surgery. We've got a contract with Gibraltar. So if anybody needs any reconstructive surgery, they will fly over to the UK to a hospital and we'll do the surgery here. And there are patients over there with chronic wounds that need surgical intervention with plastic surgery, lots of them. And I was really sad. This lady had her surgery. She'd had a rectal resection in colostomy in Gibraltar in 2009. She'd had an abdominal mesh repair. She transferred over to us, so I'll show you her wound in a moment, and she had multiple sinuses of the anterior abdominal wound, and she had the mesh that was in place, had been infected for a long time, and she'd had previous debridements locally to her in Gibraltar, which had been unsuccessful, and the plan was to come over to the UK and we'll optimise her for skin grafting. She smoked, she'd got depression because of the chronicity of her wound, the fact she'd not healed since 2009, and she was an ex-nurse and not been able to work. So the picture on the left, this is the extent of how large her abdominal wound was. You can see there that we use the negative pressure with installation, the dressing with the holes in, and you can see the pattern on the wound bed there. You can see that thick biofilm. It's nothing that you can get hold of a forceps, nothing really that you can curette either, maybe just a little bit, but what we needed that is to be solubilized and hydrated and rinsed through. So we decided to go for 200 mils. The wound bed took 200 mils of saline, 10 minutes soak on a 4-hour cycle. To be honest, that's our go-to. 4 hours negative pressure and a 10-minute soak. We did this twice a week. The dressing changes were really, really painful for her. So we used lignocaine, popped it down the tube in, let the lignocaine settle on the wound bed for about 10-15 minutes. And this was the first patient we tried this with. Really brilliant results. Because sometimes the foam can be a little bit adhered, but we want that to happen. Then pain on removal was much better. So that was after the 4th dressing change, and you can start to see that the biofilm's reduced and it looks healthy, rich granulation tissue. Something the standard dressings would just, you can imagine this kind of wound, be wet, weepy, biofilmy. And then she underwent a skin graft, and because we prepped the wound bed adequately, we had 100% skin graft take. So there is a large defect there. Psychologically, she's still got a large defect, but she doesn't need wound care dressings anymore. She can go back home and start to begin a normal life. And we've been in contact since, and her wounds are still doing fine. Okay, so next case. This was one of our cases where we used our E-Referral System. This was a gentleman in Lincoln. And what we're trying to do is to try not to bring patients over to Leicester too soon, because what happens is all our beds block. We get lots of referrals, orthopaedics, all different kinds of patients, and quite often they're not ready for us yet. So because of our referral system, we will say, can you undertake wound swabs? Can you get an X-ray? Can you get an MRI? And we'll start those conversations so that when the patient comes over to us, we've got a better picture. So this was a 53-year-old man. He had a traumatic crush injury to his left upper thigh. I think he was trying to stop his car and his handbrake was off, and the car rolled over his thigh. Didn't have any fractures, believe it or not. And the plan was to optimise him for surgery. He had type 2 diabetes, he had wound cultures that were positive for staph and strep, and on IV antibiotics, as you're aware, lived a long way away. So apologise about the quality of the pictures. These were off our E-Referral System. So you can see that dry necrotic patch on his leg, or also the surrounding erythema. He'd been sat in a hospital bed for quite a long time before he got to us. So the picture on the left-hand side is after his first debridement, surgical debridement. We would never skin graft a wound that quickly after that first debridement because that eschar had been in place a long time. If we was to put a skin graft on a wound bed with strep, we change the dressing and it just dissolves it, it melts it away. So for us to underdo that is too risky. What we want to do is optimise that wound bed, make sure we've got clear swabs before we then go on and undertake a skin graft. So again, our go-to for in plastic surgery, we do a lot of pre-op preparation, like a bit of a wound care challenge. So again, we use a negative pressure with installation, use normal saline, changed it twice a week, the 10-minute soak as usual, and we managed to get negative wound swabs before skin grafting. And this was just a week on this therapy before the skin graft was ready. And that's a picture of the skin graft, 100% skin graft. The little purple bits is where they've used the glue, as you can see. One interesting point of note that I'd like to just share with you, I think I nearly had a heart attack on the morning. We had a locum surgeon that did the skin graft, so he took the negative pressure of the installation off in theatre, did the skin graft, and we said, oh, can you make sure you put negative pressure back on to anchor the graft in place? And he reapplied the negative pressure with installation, and if anybody knows, you don't want to wash away a skin graft. I did the ward round the next morning and saw the fluid bag there, and my heart sunk. I thought this skin graft's going to be washed away, switched it off immediately, took the dressing off, and I was like, that's really clean. I daren't do it again, but maybe we might improve our skin graft take in the future. I don't know, but I'm not willing to risk it and wait for the surgeon to make a mistake again. This is a gentleman that we had transferred. He was on holiday seeing family in India. You can see he had a really nasty degloving injury to the dorsum of his foot. And again, this is the kind of wound, it's a step-staged approach. So we want to debride, prep the wound bed, and then enable it ready for skin grafting. So this gentleman, see that nice juicy vessel just at the top there? Wouldn't want to go too heavy with the debridement there, would you? So we did the negative pressure with installation. You can see on the left with the pictures with the holes, but it really cleans up the wound bed for us, makes it with that rich granulation tissue. And this we then swapped over to the normal standard cleanse foam. You can see the wound bed is there, rich in granulation tissue. and that's post-surgery, had 100% skin graft take, and we applied negative pressure on the dorsum of the foot after the skin graft so we could get up and mobilise. Years ago, we used to keep people on bed rest for 5 days, but we're a bit more proactive now. This lady, I'm nearly finished. I know we've got 5 minutes. I do need to finish talking. This is a little picture of our reconstructive ladder. And this was a lady during COVID, actually, that she's 57. She'd had multiple spinal surgeries to her lower back and developed an infection, had the metal removed. All during COVID, her husband was changing the negative pressure dressings at home. She had been through every dressing type, but a dehisced wound, but was chronic. She had been referred into our service, and this was at the time where we weren't allowed to undertake surgery unless it was urgent, but we felt that she was an urgent case. We had to be this patient's voice because she'd been left out in the community. She did need surgical intervention maybe, but she didn't want an operation. She had thick biofilm, reduced mobility, MG&O, and this is the picture on the left after they removed the metalwork. You can definitely tell an orthopaedic surgeon has had the hands on that, not a plastic surgeon. Wound dehiscence, and this is what the wound looked like in June 2021. Because she didn't want to undergo surgery, we tried the installation therapy. We'd curette the wound bed between each dressing change, apply the installation, negative pressure, but we didn't really see much improvement. And the learning exercise for us is that we start on the reconstructive ladder of what therapy we can try and introduce without surgery. The patient didn't want surgery, so for us it was let's give it a go, and it doesn't always work. You've got to be for the right patient at the right time. But what it did for us and what it did for the patient is for us to say, actually, no, we do need to now go and surgically remove the wound. So we did a big rotation flap. We excised all that scar tissue. We did a big rotation flap, really at risk of dehiscence. So to anchor that all in place, we used the incisional line, negative pressure, and we used that for 2 weeks. And this is a picture of her at the bottom, 4th of May, fully healed. So this lady had her wound all during COVID, and we've managed to get her healed up, but she did need surgical reconstruction. Learning outcomes for us on that is that our wound swab detected some things, but actually when she was in surgery with deep tissue samples, it told us a lot more. That's probably why our chosen therapy wasn't working. But also, we went on those steps of that reconstruction ladder, and the therapies that we used supported us along the way. I don't think I've got time for the last case. Shall I just skip it? Yeah. Sorry. Thank you very much. Nearly got there. I only had 1 case left. Thank you. Stay there. Relax now. Sick to death of the sound of my own voice.
So Claire, thank you very much. Has anybody got any questions for Claire? That was an amazing presentation with lots of wounds that obviously are seen more and more. Yeah. One question I've got, if no one else has got a question to start with, how do you find managing some of those wounds with the community nurses, sending them home? Because I think we are sending home more and more complex wounds into the community. How are you finding it to skill up those nurses that are having to manage these wounds with that caseload?
We're lucky that we've got a really good working relationship with our tissue viability nurses. And also, what we do, because we've got the benefit of having a community outreach service, so patients that we want to discharge early, that we would usually keep as an inpatient, and the district nurses may not be familiar with their surgical wound care requirements, we'll go and do a double visit with them, just a one-off. We'll do a little bit of education, and the district nurses so appreciate that. They're really, really grateful for your help. And what we'll say to the district nurses, what we've been doing is, you've made that contact, this is our referral system, send us the photos in 2 weeks, we're there for you. And I think this is what our community colleagues are finding. They haven't got that medical backup or that access. And it infuriates me when GPs phone up and patients phone up their GPs and they get told to go to A&E. They don't need to go to A&E. They need the right skilled person. And sometimes we say to the district nurses, bypass that. As long as it's not a medical emergency and there's no red flags, give us a call. We're here every day. Send us the photos and we'll work with you. And we'll come out again next week. We'll do a bit more debridement and we'll go through it with you again. And I think that what we're slowly doing is just trying to ignite that passion and also giving people a little bit of support, because I know from my experience, I mean, we're all worn out from COVID, but I'd say my district nursing colleagues, you know, we're there to help them because everyone's had it tough, but, you know, they want to learn. They haven't had the opportunity. And sadly, sometimes I think that education gets put down on the bottom of the pile. And we're so used to now, in this environment of, you know, chronic wounds don't matter, education doesn't matter, but it does, and we've all got a part to play in that. So we're pushing forward, yeah.
Brilliant, thank you. Anyone else got a question? Oh, there's a couple, somebody at the back there.
Hi.
Connie's running with the mic.
That's all right.
Yeah, thank you for your presentation.
Thank you.
Yes, I know COVID has a great effect on we generally. So my question is, does COVID has effect on the skin itself?
On skin itself?
Yeah.
Personally, from what I've seen, I think so. And I don't know scientifically why. I only know from examples. I've seen, like we say, I've seen an increase in necrotizing fasciitis in wounds I wouldn't have done before. I've also seen, I haven't seen in my nursing career, 2 sexually transmitted disease-related wounds. And these were people that have not long had COVID. And then they've caught a sexually transmitted disease and they've got a wound on their finger that's got gonorrhea in it. I've never seen, so I'm starting to see things that I've not seen before, and my prediction is it related to COVID and our changes in our inflammatory response? I'm not sure, but I feel from my experience probably. I don't know about anybody else. Is anyone else starting to see things that they've not normally seen? Some surprises along the way? Yeah, it's almost like we're learning things that we've not seen before. And this wound on the finger of this young man, and I was thinking he's not had a break in the skin, and when it come back as gonorrhea, I was like, I've never in my nursing career seen that before in a wound. How did it get there? And how did, you know? So yeah. But maybe that's something we could all share. I'm around all day. Come and tell me your stories. I like a good wound story of something we've not seen before. Thank you.
Brilliant. Connie, there was one more question here from Linda. I think we've got time just for one more.
Thank you, Claire. That was an excellent presentation. Do you find that with the photographs, it helps to prioritise and triage your visits so you can prioritise your visits, as we do with our photographs as well?
Definitely. I think what we've found is that our community outreach can be booked up for 2 weeks. But if we get a photograph of a patient that we start to think, oh, this early signs of infection, actually, we could just go and do with curette and that, maybe assess them whether we need to put them on antibiotics. We'll drop someone off the list and swap it around. The photographs for us are as good as the patient sends them in, but it's been really helpful if the photographs are clear. And it also saves bringing people back all the time, because a lot of the time, and also sometimes we'd go out in the community and think, why have we come out to see this? It's healed. So I think that COVID has allowed us to use the technology systems that we once didn't have or embrace. And I would have been, a few years ago, if you'd have told me about wound photographs, I'd have been really anti it, because I'm a nurse, I want to see the patient, touch them, feel them, but we just have to work differently. Yeah.
We're going to be exploring more of the virtual clinic in the conference, so look out for that.
Oh, really? Or tell me where it is. I want to go and...
That's brilliant. Well, thank you, Claire. That was absolutely amazing.